Hi, this is Brad Power, and I'm the host of the Prostate Cancer Lab today, moderator with Dr. Tom Incledon. We're honored to have today. Before we get started, as usual, I'd like to read the disclaimers, which is that this is not medical advice. If you have medical issues, you should consult your medical team. And anything you say can and will be made public. If you don't want to be made public, don't say anything. And if you want to disguise who you are, change the name on the Zoom here. But otherwise, everything will be made public. Great. Okay, so Dr. Tom, take it away. I should set up. I'm sorry. We've had several sessions on exercise now. This was an interest for all of the prostate cancer patients because of many people are on androgen deprivation therapies, so they lose muscle. They have maybe issues with heart health as a result. Many people have weight issues one way or the other, losing weight, gaining weight. And it seems like exercise is the treatment that just keeps on giving. It's like exercise is medicine. And we've had a couple of sessions. Kathy Skinner talked about some of the exercises she's helped people with for cancer. And then just, I guess it was last week, we had Carrie Winters Stone, who is at OHSU and does research on mostly exercise for musculoskeletal health. She gave us some of her research results and insights. So Dr. Tom, we met because of his work and in exercise for cancer and the things that he's done given his background in exercise. And we were particularly intrigued because he's running some of these things in a classic academic clinical trials background. He has a doctorate, and he's an academic as well as being a competitor in strength competitions. So a very interesting combination. And we thought that we would have an interesting conversation for our community. So that's the introduction, Dr. Tom, and now I'll turn it over.
Okay. So thank you very much for the introduction. What I was going to do is share my PowerPoint presentation that I had prepared. So do I have to do anything specific to get privileges to share the screen, or am I already set?
You're set.
Okay, thank you.
Click share screen. Hopefully it'll all work. Yep, it's working.
Okay, great. So what I'm going to do is first pull up this PowerPoint. Okay. So can everyone see the PowerPoint presentation okay?
No.
No, it's black. We've got a black screen.
Let me see what I did then. I may have
maybe
just
try to unshare your screen and then try to reshare just PowerPoint. Should have an option.
Yep. It does here. I have multiple monitors, so it puts the share controls on the other monitor. So let's try this first. Okay, how about now?
Yeah, got it.
Yep.
All right, and then let me see if I bring this here. Okay, so what I wanted to do is first provide a little bit of context. So can you see, let me see here. Sorry, guys, with the three monitors, it's just toggling back and forth. So I'll have to run it in this mode. So we're an integrative medical center. And so we talk about exercise. It's in the context of everything else that we're doing. So what I wanted to do very quickly is kind of go over what else are we doing here. So one of the let's say, comical statements that a lot of my colleagues would say about me is somehow I've managed to get oncologists and chiropractors and naturopaths and homeopaths all in the same team working together without killing each other. Anyone that's got any sort of educational background realizes these worlds are so far apart. They see disease, they see health very differently. So to try to get, people with various levels of educational bias and research backgrounds together, it's kind of like, imagine if you were in football and one guy has a certain offensive strategy and another guy has a different offensive strategy, and now you put them on the same team. There's gonna be a lot of tension in that room. And that's kind of what we've managed to do, is get all these guys together on the same team. It's enabled us to come up with really cool and unique strategies to the level that our cancer patients are gaining muscle, and specifically prostate cancer patients are gaining muscle. So that's one measure you would say, like, how do you know if you're going in the right direction? You're starting some therapy to treat the cancer. Well, you shouldn't be losing your hair. You shouldn't be getting weaker. You shouldn't be getting more frail. If those things are happening, that tells you is overall the strategy is not that effective, because what will happen eventually is if the cancer doesn't get you, the loss of all the muscle, the loss of the bone density, loss of the ability to stand, well, that's going to do you in. So in order to prevent this from happening, I wanted to kind of give you an overview of how we approach it. So that way you're not just hearing exercise out of context, but you're hearing about the exercise portion in the context of everything else that's going on. So very quickly, and I'm kind of summarizing data we've collected on over 200,000 people. So you're going to have to give me some privileges to make some conceptual leaps given the amount of time. If you were to just simply to Google, how many gene tests does and fill in the blank with the lab, it could be Guardant, Foundation Medicine, Natera, or Signatera, it could be Tempus Labs, et cetera. You could find in seconds that Tempus Labs right now is the number one lab for testing the greatest number of genes in tumor tissue. Why is that important? Because that then gives you more options for different treatments that are available as far as the genetics or genomic side. You could also, in the blood test, they're right now offering 105 genes, but they're pretty soon going to roll that up to 500, say 20, 530 genes. Again, why does that matter? Just more treatment options right off the bat. So you're not stuck with just like treating the label of the disease like prostate cancer. You actually have other possibilities. The problem with the genetic testing, though, is that's not a guarantee that's what's driving the cancer. So in order to really see what's going on there, you got to do some proteomic testing. And right now, best lab for that would be mProbe or Onconomics DX. So you got two different worlds, basically genetics versus proteomics. They're going to tell you different things about the cancer in someone's body. My professional opinion, my scientific opinion, you want both sets of information. And then that's what your oncologist should be looking at and deciding what is the best therapy or treatment strategy in the chemotherapy, immunotherapy world for the individuals data that they're looking at. Problem with that alone is it doesn't work 100%. Why doesn't it help every single person? We have the data because there's other variables that matter. Now we'll switch over other variables that matter. Environmental chemicals. There's thousands of studies now showing that environmental chemicals not only damage DNA and could cause cancer and disrupt your endocrine function, they also prevent chemotherapy and immunotherapy from working. So if you really want to get the best results possible, you'd have to know what's going on, like what's in the system that interferes with stuff from working. And what I can tell you from direct observation is that when we've tested regular people, so these would be, any human that walks through our doors, every person we have ever tested has environmental chemicals, which would, I'm using the term here very generically, but think of it as stuff that humans have made and dumped in the environment, so it does not occur naturally, and stuff that does occur naturally, and heavy metals. So you got like those three categories, and I'm just throwing them in one term for this presentation. We find people loaded with that stuff all the time, includes myself, my wife, my daughter, other family members. So people with no evidence of cancer loaded with the stuff. We now look at the people with a cancer diagnosis, the levels are significantly higher. So that, it sort of sets the stage that there's probably a relationship here. And unfortunately, that's ignored in standard of care medicine right now, so that you're not really getting the best possible approach if you're just looking at the genetics and the proteomics and ignoring everything else. After the environmental chemicals, there's tons of data now looking at the microbiome. And let me see if I could, if I switch over to this other screen, do you guys see my Zoom or or do I have to stop it and reshare it?
It's stop and reshare. I don't see it.
Okay, let me try this again. Sorry about the hassle. Let's see.
So I think I'll Zoom personally.
Let's try this. So can you see the Zoom now?
Yes.
Yeah.
And then if I go to PowerPoint, do you see that as well?
Yes.
Okay, I figured out. It took me a little bit, but I finally caught up. It made my second monitor, my screen one, and so it reversed it on me, and that's why I couldn't figure it out earlier. All right, so what I want you to see is this. I mentioned Tempus Labs for the genetics. I mentioned Onconomics. I want you guys to get a visual. This is what we call the KEGG pathway. These are known pathways and different areas of cancer that are so far defined. There's a lot more to this that's not defined, but it just gives you a visual of why it's so difficult to treat cancer. I'm not going to go into things like tumor heterogeneity and all these other obstacles, but the point is, there's a lot, it's a very complex phenomenon that's got a lot of multiple factors. But why did I talk about environmental chemicals? Well, because here's a paper from 2021, and there's thousands of these papers. Exposure of androgen mimicking environmental chemicals enhances proliferation of prostate cancer cells by inducing androgen receptor expression and epigenetic modifications. So basically, we're saying in English is this: even if you're blocking the androgens, that doesn't have anything to do with the androgens from the environment that are in your body. So you're not blocking them because they're already in your fat. And as you move around, they're getting out of the fat, and now they're binding to the prostate cancer cells, driving the cancer to grow and spread. So this is why you need to look at all these variables, because just taking a drug that blocks you from making your own natural androgens isn't getting rid of all the androgens in the system. And then I mentioned a microbiome, and here's 2018 paper, the microbiome in prostate inflammation and prostate cancer. So we used to think that, this is going back, I'm summarizing over 40 years of research, that all cancer was cancer. And then we learned that's not true, that, breast cancer, colon cancer, prostate cancer, different cancers. And then we thought, all prostate cancer cells were the same. And then we learned that's not true. And then as they started doing biopsies of different tumors in one person, they found each tumor has its own microenvironment. So all the tumors are different. And then, so again, we thought all prostate cancer in a person was the same. That wasn't true. And now where we kind of are today is this: we know that within a single tumor, the cells are not all the same. And not only are the cells not all the same, there's bacteria, there's fungi, there's other types of organisms infiltrating that tumor. So in order to kind of really impact that tumor environment and change the growth and the spread of cancer, these are a lot more variables than we thought about previously that have to be addressed. And so what I'm doing very quickly is kind of summarizing, how do we address it here? And this is all, let's say, background testing that's done. So that way, when we're actually figuring out an exercise regimen, we kind of have a better game plan than just saying, walk through the door and do something. So mention the environmental chemicals and microbiome. We also measure micronutrients. So it's a wide range of vitamins and minerals, essential amino acids, essential fatty acids, other antioxidants, and other things that impact. Primarily our focus with this here is lymphocyte responses. So a lot of times patients will come in and they'll say, oh, I got cancer and I was healthy and I don't know how I got cancer and I got to strengthen my immune system. Those generic statements may be somewhat true, but they're not precise enough to really help you make a decision on what to do. In order to know what immune cells to increase, you have to know what the values are. In other words, what are the natural killer cell levels? What are the cytotoxic T lymphocyte levels? And we measure all these things in response to various stimuli. Why is that important? Because that's one of the things we could measure acutely and make sure that it's actually improving. So we don't just tell someone, come in and we're going to strengthen your immune system. We take objective measures, we look at where their immune system is dysfunctional, and then we figure out how to get it, let's say, normal, and how to get the magnitude of the pulsatility enhanced so they have a greater increase of the cells that fight cancer when they exercise. And then now we'll switch over to, this is all the stuff that's done ahead of time or before we see someone. And now, as far as the exercise, think of our facility as like a hybrid of like a gym and an outpatient medical center. So we have the ability to train anyone with no arms and legs all the way up to Olympic level athletes. So it's a wide range of resources we have available. We get into things that most people never heard of. We play with like the material of the bar, what's it made out of? How does that transfer forces through the body? In other words, how do I get your muscle stronger without aggravating your joints or your cartilage? How do I make sure that what I'm doing is getting better control of your brain, engaging your muscles versus just going through, an idiot exercise where maybe it feels good, but we don't really know what the payoff will be later on. So this is the level of detail that we approach exercise that you're not getting in a gym, you'll never see in a hospital, primarily because the hospitals can't monetize it at this level. So now the main thing I'm going to focus on today is something called EWOT, or exercise with oxygen therapy. So this was, as far as I could tell, this was done as far back as the 1940s, 1950s. If there's early evidence of that, I'm just unaware of it. So I don't want to discount, prior scientists that did the homework and stuff. I'm just not aware of it. what I found very fascinating is basically German physicians, these were MD, PhD guys that kind of worked a little differently. They were kind of like in a gym, if you will. And I noticed that all these people with a variety of illnesses, it could be things like Alzheimer's, Parkinson's, or immune conditions and cancer. They were doing very simple exercise protocols by today's standards while they're breathing in oxygen. And they were claiming very dramatic improvements in let's say, health and fitness markers. And if you're reading it the first time, it would almost come off as kind of like far-fetched, like doesn't make sense. This guy's like, breathing oxygen while squeezing a ball, and now he can walk again. So this was a guy that was bedridden, just squeezing something like a ball in his hand and breathing exercise oxygen. You're like, that doesn't, how does the ball in the hand connect to his brain, helping his body move again? And so then in 2019, maybe a little bit earlier, I was hired by a company that sells exercise and oxygen therapy equipment. And they said, look, we're seeing spectacular outcomes. We got people just calling us, crying, leaving testimonials that are unsolicited, like, hey, this stuff has changed my life. And, we don't really have any basis for understanding how this is working. Could you do some research? So we put together a proposal, they accepted it, and I started drawing blood before and after different workouts acutely. And with essentially, so you kind of get a better visual, you have an oxygen concentrator. You could buy these separately. The oxygen concentrator takes room air, concentrates it, and goes into a bag, and the bag has a hose that you breathe in while you're exercising. The reason why I show everyone here an elliptical, of all the different movement patterns we tested and evaluated, exercising upright got the best responses from the immune system. So in other words, if you were sitting on a stationary bicycle, if you were walking on a treadmill or running on a treadmill, those movements did not produce the same level of increase as using both, your arms and your legs at the same time. What's significant about, I don't work for Cybex, not trying to promote their equipment, but the reason why I got this particular unit, the resistance when you're moving can go from 0 to 400 pounds. And the incline can go from very flat level to really, really high. The reason why I mention that is, with a single device, you have a wide range of capabilities, so that even if someone's very frail, they still can, start out at 0 and progress their way up. And if someone's very fit or very strong, at 400 pounds resistance with the highest incline, even offensive linemen are going to have a hard time with that. And then, I don't know if you could tell here, we integrate a lot of therapies to save people time. My professional opinion is that people should not be a victim of their disease. They shouldn't be a prisoner trapped in the healthcare system, getting treatment for hours a day and missing out on life. So we actually figured out how to stack multiple therapies together. So we could, once we got someone dialed in, we can get 4 to 6 hours of therapies done in about 2 hours. So the reason why patients love us so much is we give them way more free time with their life. So they're not stuck, like kind of, going from IV to another therapy to another therapy, and then the life is passing them by. And so this is some data from 2020. This is think of this as a normal control. So 52-year-old guy, and basically what I just want you to see, 15 minutes of exercise with oxygen therapy. These are the cytotoxic T lymphocytes. They increase from 142 to 208. So that increase of 66, you might say, well, that's no big deal. But what you have to understand is that's times 1,000, and then that's times 27,000. So we're basically saying that difference times 27 million, and that's the increase you get. I just made the numbers smaller to scale so you could see everything on the slide. So it increased 27 million cells that are fighting cancer. It took only 15 minutes. That's the main point you should take away from that slide. Now, there's other cells that fight cancer, and they're called natural killer cells. And there's the same exercise, 15-minute session. It goes from 950 to 2225, more than doubles. And again, that's that number times 27 million. So these are huge increases with just 15 minutes of activity. And by the way, after people are doing it, they say, I feel like I think more clearly, I feel like I have more energy, and my joints ache less. So my point is, the benefits of doing it are so profound throughout the body that almost every person I've ever worked with says, I want to come back and do more of this because I like the way I'm feeling. So now the compliance rates are extremely high. They're almost 100%, because in general, people want to do stuff that feels good. Now,
This- Excuse me, it looks like after, there's actually less cells.
so
Is
you're talking
that-
about these numbers here?
Yeah.
But they're not, it's so the normal response is you have a baseline value, it goes up and it comes back down. And so the curve is exactly the curve would be goes up and down is the same on both. I'll get to why these numbers are a little bit lower in a second, just 2 more slides. So keep in mind at this point here, no one in history has ever done this level of data collection. So kind of gets back to all the research on the cure for cancer. Why no detailed studies about how exercise can improve the immune cells that fight cancer. So I want to show you, I realize this is lymphoma and you guys probably have more specific concerns about prostate cancer, but I want you to see just the logic and the flow here. So again, this is data from June 1st, 2020. I try to put a little bit of a timeline so you could see how recent this is. This is a 88-year-old female. She basically was going to see a colleague of mine at a large center in Arizona and had lymphoma diagnosis several times. But essentially, the story is this. This was an easy to treat lymphoma. She goes in, gets some chemo, lymphoma's gone. A few months later, lymphoma's back. And this went around 3 times. And then finally, a colleague of mine over there said, look, go see this guy and have him do some additional tests and see what's going on. So her initial pattern that we tested her, if you could see now, we're just measuring a greater range of immune markers than I did in the previous slide. We had the data. I just want to simplify it on the other slides. And the same pattern. So things go up, come down. What I didn't have until this case, well, actually a little bit before this, I didn't have any data on a plasma microbiome. And so now I want you guys to see something with your own eyes. This is the same woman. This is same blood draw time points. The difference is we got multiple tubes and one tube is going to SnorQuest labs. Another tube is going to Periomics labs. And SnorQuest was measuring the immune parameters there. And then the Periomics was measuring the plasma microbiome markers. What we discovered in her is her first blood draw, she got 2 bacteria from spiders and another bacteria from soil. So the main thing here is that was perplexing for me, and this is outside my area of expertise, is, well, everything I know about these organisms, they can't grow in the human body. In other words, if a bacteria is evolved to grow in soil, it's not a liquid environment. It's, very high oxygen and other, let's say, chemicals in that environment. And all of a sudden you're putting it into the blood. How does it survive? So I spent some time discussing this with the head of immunology at the lab, and they basically said, these bacteria are known to basically hide inside of red blood cells and white blood cells. And I'm like, where's that data? I don't show me some papers that spell that out, because the way I was educated in medical school, if you have bacteria in the blood, that's sepsis, and there shouldn't be bacteria everywhere. And essentially, what she educated me on is there's quite a bit of evidence that there is organisms in the blood that do survive. And, that got me thinking about, the tumor microbiome. It got me thinking about bacteria in other areas of the body. So what I want you to see with your own eyes is first blood draw, look at the counts for these organisms. These are DNA counts, not necessarily linear to how many different organisms. But notice immediately afterwards, that's 15 minutes, nothing is shown. 30 minutes after that, nothing shown. 3 months later, nothing is shown. She never has lymphoma again. So given the data that we collected, I can't tell you hey, the exercise, killed her cancer cells, right? The data doesn't really show that. But what the data does show is that she does have a dramatic increase of the cells that kill the bacteria while she's exercising. And then when she's done exercising, even months later, we can't find any evidence of these organisms. So that opened our mind to that there's possibly another.
Could you
Yep.
say, could you go back to you said the cells that kill the bacteria? Could you go back to that slide? So
Is there a specific?
So CD4, CD8, and natural killer cells, I don't think they're target bacteria.
So this slide here is specifically that, well, so you should see here the cytotoxic T cells. And I'm
Yeah.
sorry, it's not on here. I don't have the total T cells. Oh, wait, no, I do. The CD3.
Okay,
So-
I think that's in the adaptive immune system and not focused on bacteria.
So if we were to break down, though, the responses of these, break down these categories here, we would see that there is an increase in the cells that decrease the bacteria. And so our interpretation right now is that exercise stimulates the increase in the immune cells that kill the organisms. And just let me go ahead to the next slide.
So
Sure.
I have a quick question as well. So how many sessions of EWOT did this person have? to
This
get
is
that?
one
Is it
session. One
one
session. Yeah, single session. Yeah. And so now let's just and keep in mind, this is all done under double blind conditions, right? So nobody knows like what's happening, nobody knows that this is the same person's blood, let's say on the lab analysis side. So now let's just fast forward to this next slide. These are all the different organisms we've now identified that when we test the person initially, we don't know what's in their blood. As we test them, these are the different organisms that have been identified that were there initially. And then after a single 15-minute session, in other words, if you took this organism, it would be like this, so it's found initially and never seen again. So all of these organisms are gone in a single 15-minute session. And that includes, those were all bacteria here on the previous slide. That includes fungi, and that includes SARS-CoV-2 and even Lyme-related organisms. So we have now data showing that on all these different organisms, a single session of exercise while breathing oxygen eliminates any evidence of these organisms at future time points. And so this is now how we've translated that into, I'm going to show you now some data on men with, one guy with prostate cancer. So this is a 61-year-old male. The relevant background is that his son is a defensive lineman in the NFL that we're working with. Sorry, not his son, his godson. And godson doesn't have any evidence of cancer, but the godson had saw his godfather just decline rapidly. And then he said, hey, I'm watching my godfather just kind of disappear before my eyes. Is there anything that could be done? And we spoke with the Tina was in charge of his medical care, and his cancer was very advanced. We didn't really think, we don't have any evidence that where he was, that we could turn that case around and beat the cancer. However, we do have lots of evidence that we could get him from the current position he was in to a much better position. So just to be blunt, he was bedridden and needed a care nurse assistant to help clean him up because he's going to the bathroom in his bed. When we tested him, this was his baseline data. This is cytotoxic T lymphocytes. And I think this next one here is his natural killer cells. We were able to get him in and start exercising. He was barely able to do 15 minutes when he started. He should have passed away around this October 2020 time point. He got to March 1st, 21 when he passed away. And what I want you guys to see is palliative care. So he was put on several different chemos shortly after we started working with him. And you could see despite the number of medications he was on, there's roughly like a 2-week phase where you don't see much change in, let's say, the natural killer cells. But somewhere around here, you can see they definitely are much higher. A couple of takeaways. This period in here, we've now identified in a number of different patients with different cancers. In this particular slide, what's not really clear is at this point, we didn't know like the number here, like what's a good value versus a bad value. No data on that. So we learned over time is that every patient that gets over 1800 on the natural killer cells, they wind up surviving their cancer, meaning they're still alive today. The patients that did not cross that 1800, eventually all of those patients have passed away. Now, kind of like we didn't learn that till later. And so now going backwards and looking at this slide, you can see this poor guy, was under 300. So, it kind of what you adopt the consensus of the medical team at the time is, this is too far gone. Now, this is somewhat of a biased interpretation because we're just looking at like 2 cell lines starting the immune system. There's a lot of other stuff going on in this guy's case. But the main point I want to make sure everyone's aware of is he was bedridden and basically was given just a very short period of time to live. When we were done, he went hunting on 6 occasions carrying 9 pounds worth of rifles. And just basically, enjoying his life till his last minute. And when he passed away, he went to sleep. He wasn't on morphine or codeine anymore. We got him pain-free. And he was able to actually, go out and do things at a level that most people didn't think he had cancer anymore. So we couldn't say we changed, in other words, he still passed away from the disease. We definitely could say the quality of life is not even close. And the amount of time beyond where he was given is way longer. And one of the things we learned from this is that medical system doesn't really distinguish between lack of use and the disease process. It's all kind of lumped together. So when a physician sees a patient and says, well, you got X amount of days or weeks or months or years to live, if we go to that physician and say, show us your data, where you kept track of everyone that left you. So they went somewhere else, they didn't follow your advice. Where's the data on those people? And they don't have it. There is no data. Once you leave a doctor's office, they're not following you every month and saying, hey, where are you going for treatment and what else are you doing and what kind of therapies? It's kind of like ignored information. And so what do we kind of learn from, I guess, this EWAT and immune function? So exercise stimulates acute and chronic increases in cytotoxic T lymphocytes and NK cells. The exercise with oxygen therapy increases blood oxygen more than exercise, and the extra oxygen allows you to do more work. That additional work, and we're talking about if you're fairly healthy, you're walking around with O2 saturation, let's say 96 to 98. So we're talking about a 2 to 4% increase in the O2 saturation levels. But that little bit of 2 to 4% can allow you to do up to 25% more work. So it's a big payoff is what I'm saying. This extra work increases the epinephrine from the adrenal medulla. And right now the thinking is that the epinephrine is what stimulates these cells. So what we're currently looking at is additional strategies to increase these cells. In other words, now that we know we got a goal of like 1800, for the people that are nowhere close, are there things we can do to help them get above 1800? And then here's some other, let's see. So I mentioned that the exercise stimulates the acute and chronic increases in the cytotoxic T lymphocytes, natural killer cells in healthy people and in patients with cancer. The difference might be where are they starting and where do they go? And the exercise with oxygen does this way better. And also now we have ample evidence that eliminates all kinds of pathogens. And it was outside the scope of this presentation, but what I did is we started finding this. Keep in mind, these were novel findings that no one else was really reporting. But when I talked to different immunologists, what I found was kind of surprising is a lot of them kind of knew this. And when I would say, well, how did you know this when it's not really published anywhere? And what they would tell me is that, well, in their in-house data, they found that if they had people at rest, they didn't see as many things in the plasma microbiome. But if they had them jump up and down and did a blood draw, they found more of these, more organisms, if you will. And so then I said, well, where are these organisms coming from? And so there was the first response was, well, from inside cells. So later on, what we did is we did microbiome testing from the sinus cavity, from the back of the mouth, and we did urine, and then plasma microbiome, skin scrapings, and we did lower GI microbiome tests. So think of it as we did microbiome testing from a lot of different areas of the body. And what they could do is just then say, okay, the DNA of those organisms was either seen or not seen. And then later on, we would attribute it to, let's say, if someone brushed their teeth too hard, the bacteria in their mouth, that would be one vector by which it could be discovered later on in the blood. And so there's a lot of fascinating stuff that came out of this from the microbiome. And where we are right now is, how does this benefit people collectively through the different labs and the different doctors at our institution? We've probably tested a little over 200,000 people. When I look at all the different drugs and supplements and strategies that have been tried, I've not found anything that comes even close to stimulating the increases in natural killer cells and cytotoxic T lymphocytes. And then one of the limitations when we were doing this testing, we were using a lab called SnarQuest, and think of it as their level of detail on the immune responses. Let's say they group a lot of stuff together. We're now using a new lab called Cyrex, and Cyrex does something called a lymphocyte map, which breaks out all the, let's say, immune responses to much greater level of detail. So address some of the questions and asked earlier. So I don't have those slides here, but kind of think of it as like this. Instead of having like one data point, we now have like over 20. So we're seeing all these other details. And the other compartments, the other things about this I think are important to make is we're seeing people make improvements in brain function, heart function, lung function, reduction in joint pain. And again, 15 minutes of exercise, the minimum would be 3 times weekly. If I have someone very frail, we exercise them every day. And the reason why we exercise them every day, it gets them from where they are, meaning they can't stand or they can't walk, to where they have their functional independence faster. We could usually get people in wheelchairs walking anywhere from the same day to 12 days. That's usually the time it takes. So they're strong enough now to do certain things. So I hope that, I know my presentation, I try to rush a lot of stuff to kind of squeeze everything in. I know some of it, I really simplified some of the slides. They may not satisfy everyone's curiosity, but I hope it was educational enough to get people's curiosity piqued.
Thanks, Dr. Tom. Just a quick question, and then we can use the hand raise function for others who have questions for Dr. Tom in the remaining 15 minutes or so. What question of access? So let's suppose that a number of the patients here are interested in learning more about how they can access the therapies you're talking about and the testing. Do they need to go to Arizona, or do you can you operate virtually?
So the labs provide on-site phlebotomy services. So I guess the simple answer is no, people don't have to come here. But I guess once you have the information, we don't know what the lab results say yet. And then once the lab results come in, the way that we kind of interface with people is we look at the lab results, and then you have sort of like it's kind of like the same format you might see on the lab results from Garden or Foundation. It's kind of like FDA approved therapies for that given indication, then the the FDA approved therapies, but for a different condition. And then we have sort of the non-FDA approved therapies. And where it's kind of interesting is that some of the botanicals like IV resveratrol, IV curcumin, or IV sulforaphane or quercetin, they provide benefits through a large number of pathways. So let's say one approach might be using, let's say 2 to 5 chemotherapeutics, immunotherapeutic agents. And then you go over to the botanical world, and maybe 1 or 2 agents can duplicate everything that was done, let's say, in the non-botanical world or standard of care world. So when people then they're put in a position, they can make a choice. Where do they feel more comfortable? And then, then that's up to them, whatever they want to do. And then we can guide them which direction to go from there.
So when you just spoke, you spoke about botanicals, which is like supplements, which is more like integrative oncology. and less the focus that you had here on the exercise. So what kind of exercise regimen do you recommend, or how can people get personalized guidance on exercise?
So, well, so first, I guess, so, if someone was say to contact me and say, let's say I can't do any testing, I would always recommend some objective data first, because you're not going to get the best results. For example, if you have several nutrients that are low, you're going to be working out in the gym and making progress at a snail's pace. And since time is so critical, we want to do things in a way that enhances the rate at which we experience results. We don't want to do things in a way that drags them out over time. And so we'd want to do some micronutrient testing. We'd want to look at, their immune markers and their environmental chemicals. If that stuff's, let's say, messed up in the background, they're not going to get the best results from their exercise. Let's assume now that's addressed somehow, and now we got a, someone that we can address the exercise in. We'd see where they at. So I guess if we had like a model, one way of looking at how do you enhance the function of that system is, let's look at what's rate limiting. So like yesterday, I had an individual come in with a very advanced prostate cancer, and just asked them, what is some of the problems you're having, the greatest difficulty with right now? And he said, well, if I fall down, I can't get up. I said, okay, no problem. That's going to be your new exercise program. We're going to put him on the ground and see where he's weak, and then figure out how to get him stronger so he can come up off the ground and not be afraid of falling and stuff. And so I brought him and his son into our gym. I had laid him on the ground. I actually had him use a bench to get to the floor, and then studied where's his, he's basically leaking the left leg. And so now we develop an exercise program around where his weakest muscles are.
Okay. A question from Saeed and then Jim Ward.
Yeah.
Saeed?
Yeah, hi. Thank
Question
you.
two.
This is a great talk. I just want to support this talk because based on my personal and close friend experience, I think the combination of these two can do magic. Sometimes for sure we don't know exactly why. Then I just want to say thank you. And the last part Doctor mentioned about the quercetin and the other botanic drugs. All my analysis on the omics data again supports your suggestion. These drugs in many cancers shows the positive result. Then that's it. Thank you.
So Dr. Tom, that was Saeed Sayad, who's in Toronto, and he's a data analyst. He looks at public data sources and does.
I'm also a medical doctor, just to make sure.
And
Thank you.
But I
His
don't
company-
do practice here, but I'm a medical doctor and also biochemist. And yeah, that's it. But that's a personal experience. It's not based on. And the analysis on the omics data, as it said, all of them support your point on quercetin.
Thank you, Saeed. Jim Ward, you had a question in the chat.
For any background noise, I'm in the kitchen. It's kind of busy here. But so as I posted in the chat, I'm curious. We've seen a lot of data based on test results following exercise with EWAT, but it seems like there would be an interest in establishing, I guess, baseline for lack of a better term. But client comes in.
Uh-oh.
I'm sorry, I didn't hear the rest of
I
that.
think I can ask it. He was wondering if the positive changes that have been shown, demonstrated through testing, if you've done any exercise without EWAT studies versus exercise with EWAT
Sure.
versus placebo.
Yeah. So first, the simple answer is yes. In terms of when you say like a placebo,
or control, somebody who's not exercising.
So
Or after, I just think about the same.
well, so keep in mind if So when you turn on like a placebo in this type of situation is not going to be very useful, only because the oxygen concentrators are very loud. So if they're running, you kind of know they're on. Two, usually you have a face mask, right, when you're doing that. So again, so there's some practical things like we could set it up where there's a generator running and there's no oxygen going into the mask, but people would feel the difference in the airflow right away. And so they would know. We could probably set it up so it's like room air going into the mask, but that would be cost prohibitive right now. In terms of have we tested just people, let's say, without the EWAT system running and compared that? Yeah, that's what we piloted out back around 2019 and 2020. And that's how I was able to say earlier, like you're just increasing O2 saturation a very small percentage, anywhere from, let's say, 1 to 4 would be the range. But that little increase in the oxygen saturation of the, say, red blood cells, that results in up to 25% improvement in exercise, and basically comes down for most people. The rate limiting step is they just run out of, they don't have enough oxygen at the end of the electron transport chain to allow them to continue to exercise. So what we're doing is getting rid of like the weakest link in that system, and that's how they're able to do more work.
Let me jump in with a follow-up. I'm sorry, my system got a little glitchy, but if you can hear me now.
Sure.
Yeah, I think the curiosity on my part, and Russ, and I'm sure others, is, you know, we all have heard, read, and understand to some extent the benefits of exercise as far as boosting your immune system and cancer control. But, you know, we're all very curious and would love to know more about the benefits quantitatively, let's say, of that exercise. You know, and even if exercise, you know, with the EWAT enhances it, it sounds like you did tests and got results that show that on some level that exercise does provide a benefit. And then we just, you know, I'm personally very curious as to what's the extent of that benefit. If you've got lab results that, you know, plot that, demonstrate that benefit, you know, I'd love to know what that is without EWAT, because I don't have any current plans to jump onto the EWAT, you know, bandwagon, so to speak. Don't know what that would entail, and we just want to know, well, fine, how much does exercise benefit you in terms of those numbers before you introduce EWAT?
Sure. So my current line of research, though, is looking at multiple strategies to enhance the immune response. So to go backwards and take all that away and just do exercise alone, that's not really what I'm in the focus of doing right now. So it's kind of like, once you learn something that works, you don't say, let me go backwards the other way. What you want to say is, how do I make it better and better and better? Because I think what you're kind of missing here is a context of time. We have patients that come in from just visually, most of you guys look, let's say, a lot healthier, a lot more able-bodied. Remember, in the context, what I was saying is I have people coming in that can't stand, they can't walk. So I don't have like 6 months to say, let's see what happens. We need results fairly quickly. So the bias of that kind of environment is that we're jumpstarting, we're doing a lot of things at once because they may not be around in 30 days from now. And so if we're successful in getting the results we want in the first 12 days. Now, to your question about, you know, some of the long-term benefits, one of the biggest mistakes I see people making is they go, well, I exercise. And they come in and then we look at their exercise model. They have no plan of progression. They have no understanding of the difference between hyperoxia dramatically enhances brain, heart, lung, immune system function, period. So now that you know that, why would you not want that? It's like to say, well, I won't do that for whatever reason. That just means now you're just going to make things harder. On the other hand, hypoxia, that means low oxygen. That helps you add muscle faster. And those two simple things, just playing with oxygen concentration, they're very basic. There's lots of studies on that, yet I don't see anyone even making that part of their exercise strategy. They're just doing like room air all the time. And that's one approach, but what you're trying to do then is you're trying to go with something in the middle that gets you from getting the experience of the best possible environments. So if you're seeing like your muscle mass is going down, you got to basically create a hypoxic environment. There's lots of ways to do that. We didn't cover that because that wasn't part of today's presentation. On the other hand, if you see like your fitness is declining rapidly, then you want to try to get it the opposite direction, hyperoxia. If you were to just exercise normally, you're in the middle. So you're going to get like the average of the two extremes, which will work, but it's not going to work as well as creating an environment that enhances your abilities to progress. And that's what I'm showing you here is we've now moved towards looking at tools that help people progress faster, meaning in their fitness, or if it was a different presentation, in their muscle strength. And to put things in a different context, we have 88-year-old women maxing out pieces of cardio equipment in a gym. I want to make sure it's clear. So this, 130-pound woman is doing 400 pounds of resistance on a Cybex arc trainer. If I probably brought all you guys in and tested you, the odds are pretty high. Very few of you would be able to do that much. And so now you have to look at relatively, how is this woman's fitness progressing faster than mine? And this was stuff that we figured out in the 1980s. So in the 1980s, my research group under William Kramer at Penn State Center for Sports Medicine, we figured out how to take average women and make them stronger than average men at a time when women were told don't exercise and stuff. And that's, we got 40 years, research that we've been doing. So it's not, we've kind of moved forward. And some of the stuff, it might be not as, let's say, obvious in other areas, but it's stuff that we've been doing for a long time. So I hope I answered your question, James, to your satisfaction.
Yeah, it's obviously kind of a complicated realm, but thank you.
Amit, you had a question?
Yeah, so a little bit similar to what Rick is asking in the chat. I mean, as a patient, what's involved to, for me to kind of get a consult, and what's the cost of service? How does it work? We obviously we're not in Arizona, most of us. How long is the kind of the minimum period? I mean, you showed the chart that, hey, just one kind of EWAT treatment actually helps somebody for a very prolonged period of time. So can you help us understand the cost of service and time and what's involved in?
Yeah, sure.
In
So the initial contact, you fill out a form on a website. There's no charge for the first sort of consultation, if you will. It's 30 minutes long. We kind of go over your specific case and then just kind of point you in the right direction. Most people there say, yeah, I definitely want to move forward just because it's logical. There's nothing that's, shared that people say, oh, I never heard of that, or it's unreasonable. And then when we do after that, most people do it by Zoom, just more convenient, I guess, but you could physically come here. I didn't mention this earlier, but everybody's welcome to tour the facility. We give quite a large number of tours throughout the week, the year, whatever time metric you want to use. We have doctors from around the world come here, particularly there's been a lot of interest in hyperbaric oxygen therapy. And so we have different groups doing research in that, because I've made some very bold statements that if you're doing that, you're going backwards. Anyone that does EWAT that you see right away, way better results than versus hyperbaric oxygen therapy. And I've presented different sets of data in other medical conferences about lying is never the solution. You want to be standing and moving. If you're not sure, just move more. It's that simple. In terms of, costs and stuff, it's $360 an hour. People pay based on time, and typically initial consult might be 2 to 4 hours. So we usually just try to cap it at $720. That way people can get what they need and not have like a fear factor of, oh, I don't, how big is this bill going to be? And then from that consult, we provide like a list of recommendations, and those recommendations vary. The general recommendations that I made at the beginning, as far as like Tempest, Onconomics, right now, I would do that with every person, regardless of their cancer or their staging, because there could be data that's gleaned out of that could really help someone. In terms of the micronutrient testing, environmental toxins, microbiome and stuff, that's paid out of pocket to the labs directly, and that's really dependent on what people's budgets are and what they can afford. And those fees are determined by the labs, but we basically kind of give you like a line item of everything. And then after you get all that, we have a conversation, discuss what's easiest for you to implement. We have everything from people that, can't afford any testing unless their insurance covers it, to people that just do whatever, whatever they want because they're not worried about money. So I don't make those decisions for people. They make that for themselves. And then testing.
So coming to your facility for an EWAT session, and what is the cost involved of that?
So the EWAT session is $150 per session. And then some people buy packages of 12. And so then the 12 sessions is $1,500. So you're getting a discount of $300.
Okay.
And if I could, I have a couple questions. I'm not sure if you're done yet.
I think I answered Amit's question. Did I miss anything?
Okay.
No, that's fine. Go ahead, Russ.
I was wondering, thanks. I was wondering how blood flow occlusion or resist BFR, how that plays into the hyperoxia, and how just supplemental oxygen canisters, how those might help. Because I know a lot of people, financial constraints, they are not going to be able to go out and get consults and whatever, even though they're minimal, the startup fees or whatever, even though they're minimal. I understand that, but Arizona is a long ways away from some people. So if they want to get EWAT, well, how can they do something kind of similar, if you will, or something that might have some benefit in addition to their exercise? I was thinking supplemental oxygen or BFO or BFR.
So blood flow restriction training is the opposite of the hyperoxic training. So when I was saying earlier about hypoxic training, so basically there's lots of ways you can reduce oxygen getting to the muscle. Simplest way is just hold your breath, and then while you're moving. So you're going to use up the oxygen in the tissue and you're not going to be replacing it. For some patients, that might not be a smart strategy because they may have an increased risk for stroke and heart disease. But, my point is, in terms of expense, that costs you nothing. And so you got everything from zero, on up. Now, in terms of tools you can get, there's lots of BFR tools, and a BFR tool is anything that restricts blood flow to the working muscle. We've got, I don't know, tons of these devices. Some of them range over $7,000. And after I analyzed all these devices, I found that we could get almost exactly the same results buying what they call Velcro cinch straps from Amazon. So basically for about 16 to $20, think of it as like a belt, but it's small enough to fit around your arms or your top of your thighs. And it's got Velcro on it. So you just pull it really tight. And then you put the Velcro attachment on. So it holds the occlusion over, let's say, the blood vessel, in the upper arm. So basically you're running it right between the biceps and the shoulder. And then same thing, you're going up as high as you can on the thigh. And then you would just use that while you're doing your weight training. And the nice thing about that is that you could reduce loading, but still keep muscle protein synthesis rates high. So you could actually get improvements in glucose clearance, get improvements in reducing cholesterol, and stimulate muscle growth. In other words, with lighter weights without stressing out your cartilage. So that might be an advantage for people that have any joint concerns. Some other nice things about that's often overlooked is there's a lot of comments made about different diet strategies. Most of the diet strategies that are usually suggested are based on testing outside the individual and then forcing that data on the individual. Where we are with precision medicine, we're way more advanced than that. You'd want to test the individual to see what's there. Now, if someone can't afford testing, then by default, they got to go, with strategies that are based on data on other people. But if you could test your immune reactions, your genetic reactions, and your microbiome, that gives you a much better awareness of how your body handles different foods and then what type of food you should be consuming. And why do I mention that? Because when we're talking about, anything you put in your body gets in the blood, let's say, like something you're ingesting, and then that could potentially feed cancer in the body. And so things like fasting or intermittent fasting, limitations with those approaches is that micronutrient levels go down dramatically, and then immune function gets impaired over time, maybe not acutely, but eventually. And things like, say, a ketogenic diet disrupts the microbiome. So some of the strategies that have shown some improvement short term, when we got long-term data on people, what we see is there's other things developing that are counter to the long-term goal. So you mentioned about the BFR, and the second thing about other ways to increase like a hyperoxic condition. When you're exercising maximally, you're going to breathe in about 60 liters a minute, give or take. Basically, taller people, bigger lungs will probably take in more than shorter people with smaller lungs. And when you're getting an oxygen concentrator, the best concentrators on the market right now produce about 10 liters a minute. Most people, if they have the oxygen concentration set too high, they're probably going to get a yield of 8 liters a minute. So what that means is when you're breathing in like this little nasal cannula, you're not going to get enough airflow to accommodate how much you need. And so that's the reason why having a system where the oxygen gets stored in the bag and then you're breathing it from a mask, because then as much oxygen as you need, if you need 60 liters, you're going to get 60 liters. If you need less, you'll get less. So around, would you just have a nasal cannula? Could that provide some benefit? Possibly. I don't know that. I haven't really tested, that environment, those conditions, I should say, just because we already know it doesn't produce the best biological outcome. So when we're looking at, the other end, how do we optimize results? So Russ, I hope that answered your questions.
Yeah. So there's no real hard data on like supplemental oxygen, just little canister you breathe in or whatever, a little mask. There's no real data on that. I understand there's not. I was just wondering if there's something that somebody can do if they absolutely cannot get out to.
So think of it this
Scottsdale.
way. So you don't have to come to Scottsdale to exercise. You could do that anywhere. You don't even need equipment. So
Yeah, but I was thinking the EWAT system.
Yeah. Well, if you want to do EWAT, you get an EWAT system, right? And if that's outside the budget, then you just don't do that. You just do, you would just maybe exercise. You could look at other options like exercising in a way that provides a progression that you improve your fitness. If your fitness is, in other words, if you're doing more work in the same amount of time, that's going to provide a stronger stimulus to get those immune responses that I showed you earlier. So in other words, if you're burning 10 calories a minute and now you're going 11 calories a minute and then 12 calories a minute and then 13 calories a minute, you would see that your peaks and your immune responses are higher over time.
Yeah.
Dr. Tom, how are you set for time? I want to be respectful of your time. We've run over the hour.
I blocked off 10:30 because usually I have a lot more questions than that go beyond. So I was kind of prepared for that today. Okay.
Let me just then, Rick had a couple of questions in the chat, and then after Rick does it, I'll turn off the recording and we'll go to informal discussion. But Rick, you had a couple questions.
Yeah, sure. I think you already answered the, coming out to Scottsdale and how much does it cost roughly. So I feel good there. Let's say I want to do something today. Oh man, I'm inspired, which I am. I've been doing what I call HIIT workout on an elliptical, which is repetitions of 30 seconds as hard as I can and 90 seconds recovery and repeat. Is that better than just slogging along for 40 minutes on an elliptical or anything we can do today?
All right. So I guess the simple answer is I think the interval training is very, very effective. So, but I want to kind of sort of bias of my presentation. Remember, I'm dealing with people that may be a lower level of fitness than you guys are, right? If I have someone that can't stand and you're doing sprints on a bike, there's a big difference there. So let's say what I probably should have maybe added is that we get everyone our goals, and this is internal to our center, and it's more based on observation, not so much like hard scientific data. But our internal goal is that we get everyone to a level they could do 1,000 calories in a workout. So to your point, they're doing, let's say, like more of a steady state exercise, and they could watch with the stuff we have, they could watch a TV show, they could play their music, they could listen to podcasts, they could do whatever they need to do to get their head in a space where they're going to go. And they're going to take anywhere from, I've had some beasts that do 1,000 calories in 25 minutes. And those are definitely like the genetic freaks of society. And then you have the guys that are more like normal, that are somewhere like 90 minutes, right, to get to 1,000 calories. Once they get to 1,000 calories, what it does for us, I've never had any of those like at that level. No one has any brain, heart, lung issues. So think of it as that's our internal level to say, okay, you're now safe and fit enough that we can do whatever crazy stuff we want to do on the sprinting side with you and not worried about a stroke or a heart attack. So kind of think of it like we're thinking safety with the progression, not just progression alone. Now, once they hit that 1,000 calorie session, they'll probably do that maybe 2 times a week. They'll do 1,000 calorie workouts. And then in between, they're doing a variety of, intervals. So it could be something like what you're saying, where there's like a work to rest ratio of like 1 to 4, 1 to 3 around there based on their fitness. But then eventually it's going to go upside down. And so we'll have them like sprinting 20 seconds and then do nothing for 10 seconds and then 20 seconds. So think of like 20 on, 10 off. And then eventually we're working them to something like a minute on, up to 2 minutes if they're super fit. Some people do respond ridiculously fast or well. And so they're going all out for, basically near glycogen depletion levels. And then, rest 20 seconds and do it again. And then what we do at that point is we'll either have them using oxygen or we're doing like BFR training. So in other words, one workout would be, think of it as they're doing high oxygen while they're doing their sprints. So it helps them recover. Another workout would be no supplemental oxygen. So room air with their, we call them occlusion straps on their thighs and let's say their arms while they're doing their sprints. And they're using, we always have them doing all 4 limbs unless there's a reason why they can't, use a limb, like whether it's that they're missing the limb or there's joint pain of some kind or some other dysfunction, like maybe they just had surgery in that area. And then we use echo bikes here because it's got the upper body component with the lower body component, but they think of them as like the old school Schwinn Aerodynes from years ago. And the reason why we use that is they could actually put one leg up while they pedal with one leg and the arms are moving, or they could put one arm down. Just in other words, they could pick and choose which limbs they use if they have some dysfunction. So that allows us to kind of get as many joints or limbs moving as possible. And that's really the critical thing, is figure out a way to move as much as you can while you're doing the movement, because that is definitely linked to better immune responses. So right now, the intervals you're doing, what I would say is fine. Just look at ways that you could eventually work towards more work and less rest in that, same amount of time.
Okay.
Oh, one other thing, we typically have people when they're doing their sprints, if you will, intervals, they're starting like 1 to 3. So we kind of get a sense of how they respond. So we're looking at like heart rate, blood pressure, like afterwards. And we usually see is some people take a while to respond, but eventually getting them to 20 sprints. And by the time they get there, they could look like they're not going to make it as far as their fatigue level. And then within a minute, they're perfectly fine. And so what you see is the recovery is like post-exercise is better and better and better. So that's one way to gauge, where you are. Like if it's taking you 4 minutes to recover, then the exercise stimulus was too much for your current level.
Okay. There's a guy called Dr. Kevin, and he does insane 20-minute elliptic hit workout, and then insane, and it's 2-minute intervals, 30 seconds max, 90 rest, and that's what I've been doing.
Yeah. So keep in mind, I don't know how long you've been doing it, but eventually you're going to adapt to that stimulus, right? So you're going to have to just mix it up a little bit so you can avoid a plateau and continue to make progress.
Quick last question. You said we try to do a tempus on everyone, and obviously tissue is an issue. So
okay, so
blood.
yeah, so the tempus, you do the initial tissue once, unless you had like another biopsy and you want to see what's in that biopsy, but you do the tissue once and then everything after that is blood. And then one of the ways you could evaluate your treatment response is just do that every 30 days. And then you're seeing what's showing up. And what you're hoping is you get to a point that nothing is showing up in the blood test.
And by Tempus blood test, do you mean mutations?
Yeah, so they do the XT test like on a tumor tissue and the XF in blood. And then they're right now doing about 105 genes. They're going to somewhere around May or so. They'll be rolling out the 523 expanded panel. And then we're one of the groups that's going to be having that available for patients. I don't know their deployment schedule, so I don't know how they're figuring out like who does it, who doesn't. But for now, I would just say 105 in the blood until they got it widespread available throughout the US, and then it'll be 523 everywhere.
Thank you.
Yeah. One of the things about that, since you brought up Tempus, is part of relationships goes to the volume of tests that we do with different labs. We can get things positioned where we could really help people save quite a bit of money. Some of the most expensive tests are some of the genetic testing and perhaps proteomic testing, like those things out of pocket could easily go $3,000, $6,000 for one panel. So usually we do pretty well helping people get insurance coverage if they have insurance. So their out-of-pocket expense may be down to 0 to 100. And that's something that could really go a long way in giving you more treatment options later on.
Yeah, that's
Brian,
awesome.
Brian has his hand up, and he can comment on that because we have relationships both with Tempus and MPro on that. Brian?
Yeah, I had like 3 questions, but the first one I'll just kind of dovetail into testing. So XF plus, like I think you can get it now. I know that I've gotten it, and several other people have gotten it. But one of the great things about prostate cancer, if that actually goes together, is that we have PSA. So are you tracking PSA for prostate cancer patients that are doing your program?
Yeah, so we don't just do PSA, we do alpha fetoprotein, we do HEV4, we do CA59 and 125 and CEA. And the reason is, I'll have 9 out of 10 guys, none of those proteins are elevated, or I should say the other proteins. And then you get the one guy where he's got several proteins that are elevated. And, we don't look at these protein indications as like a linear, like it's not a count of how many cancer cells are active in the body, but it's just another indication of a pathway that could be inflamed, that could be expressed by the cancer cells in that person's body. And to make sure we're not missing something, we want to make sure that all the numbers are going down, not just like 2 out of 3 or something, or 3 out of 5 or something like that.
Okay, so you are looking at PSA as one of those. Is that correct?
Yep.
Okay, and what is the correlation between the exercise regimen and a reduction in PSA or any of these other proteins?
So,
because sorry, just to qualify that a little bit more, one of the challenges with prostate cancer is, it's a cold cancer, and so while we may be raising our immune cell activity, it won't do any good if those immune cells aren't actually killing the cancer. And so I'm trying to get to that. How does this exercise actually kill the cancer?
Yeah, so what I could tell you that in some cases, within 6 weeks, there is a 50% or greater reduction in a total burden of cancer as assessed by a PET scan. In other cases, no impact at all. In those cases where there's no impact at all, what we usually see is there's an unusually high burden of environmental toxins in that person. And if you were to look at the individual effects of those environmental toxins or chemicals, it literally says immunosuppressive. So then you're not going to see the patients increasing above that 1800 level I mentioned earlier. So how that impacts PSA, it's all over the place. It's not going to be a linear response because think of it as, so doing the exercise is beneficial, period. Whether that translates to a direct reduction, let's say, we'll just say cancer burden in the body, there's other factors that are involved. And in some cases, we may know those factors very well, but in cases where people, let's say, don't have the funding to afford the testing, and there's no financial assistance available from the lab to pay for the testing, we just don't know what else is involved in those cases. So there's not really a direct intervention that could be done because we don't know what we're dealing with. But what we do measure when we can see the decrease in environmental toxins over time, think of it as you got like multiple variables that you're looking at over time. It's not a linear relationship unless there was a magic way. If we could somehow get rid of everything that damages DNA, everything that suppresses immune function, whether it's missing or whether it's too much, like correct all those things, there definitely would be a much more linear relationship than what you see in some cases. So I know that wasn't like a direct answer, but it's just not that simple.
No, I understand the complexity. It's just that for better or for worse, PSA is a marker that prostate
Sure.
cancer patients use as a proxy to understand growth and regression of cancer. It varies across all of our patients here. So for example, I have a high tumor burden, but I have a low PSA. But still, I know the relative amount of growth based upon increases in my PSA. So second question is, all of our patients here are on some type of therapy. Have you looked at certain types of treatments that improve or hurt the response to EWAT? So for example, let's say I'm on chemotherapy. Well, chemotherapy plus EWAT may be a good thing, right? We're using chemotherapy to potentially turn the cold tumor hot. You fire up your immune system through EWAT and bingo, maybe you've got a better solution. I'm obviously making this up, but I'm just curious if you've looked at treatments that patients are on and those that seem to do better based upon their treatment profile.
So, so first, I would say if someone has done the Tempest testing and M-probe economics testing, my general view is that those patients are more likely to get better results from, in other words, getting a medication that's better fit for what's going on inside their body. So you have that, let's say, your precision on a treatment recommendation from the chemo, maybe immuno side. In terms of those drugs, some are very immunosuppressive. So those drugs will reduce the immune responses to exercise, period. It won't matter if it's EWAT or lifting weights, doesn't matter the form and the mode. But still doing the exercise does help. Think of it as instead of you coming down to zero and staying at zero, over time, you're at least a little bit above that. So it would depend on the drug. Like we have a case right now where the white blood cell count would get to zero, and then the doctors would put the patient on Neulasta to kind of stimulate the cells back up. And then once the Neulasta would kick in, the white blood cell counts would go sky high. And then in between the treatment of the chemo, you'll see things normalize and he gets a normal response to EWAT. But in between, there's times when if you're starting at zero, you're not going to get a very strong response because there's nothing really there. So a lot of it depends on the type of medication that's used, but you would still want to continue exercising because remember, there's a lot of benefits to exercise in general, and then those benefits can be enhanced when you add in supplemental oxygen.
Got it. Okay, then one final question. You mentioned that you've done some work incorporating the microbiome. I think we might have talked about this a couple months ago, but are you working with Rob Knight's Cancer Center at UC San Diego and the microbiome work that he's doing? And the reason is I'm just curious if there might be some opportunity to to collaborate there, maybe incorporate your EWAT and make it more accessible to folks on the West Coast?
Sure. So I'm not collaborating with them. The lab we were using to handle the microbiome testing previously was a Periomics. That lab is now, COVID was really hard on them, so they're no longer, viable. We're now looking at another group, Cosmos ID, I think it's called. They're considered one of the largest microbiome analytics centers in the world. They're sort of like the back end for a lot of companies claiming to do microbiome testing, and they just take their samples and send it to those guys. So that's where we're at right now. If you want to set up an introductory email or something, I'd love the opportunity to talk with some other guys.
Okay, great.